Consumers Association, and I'm joined here by my colleagues Claudia and Monica, and our friends also at partnering with us at the Advanced Care Planning team at Canberra Health Services, and we're also supported in this Dying to Know Day event by our lovely panel members and speakers from a variety of end-of-life services here in the ACT, and I'll introduce those people as our program gets to them. So thank you for joining us. As we begin this event, I'd like to acknowledge that we're meeting today on beautiful Ngunnawal land and pay my respects to elders past, present and emerging. I'd like to thank them for their care of this country and their contribution to the life of this city and this region. So Dying to Know Day event is an international event that's usually held in early August, and its purpose is to make a space for us to have the conversations and find the information we need about death and dying, and by doing that to bring us information and knowledge and power and some comfort about that part of our own life's journey, and perhaps if we're supporting other people through the end of their life, enable us to better and more easily do that. So a few housekeeping things just to go through before we begin our program. We are recording today's event, and that's so we can pop it on our website, the Healthcare Consumers Association's website, after the event, and people who might have missed out can then have a look at it. We have collected some questions to ask our panel members in the second half of the program. We've collected them from you as you've been registering for this event, but it might be that some questions occur to you as we're going along. And if that happens, please feel free to just type them into the chat, and you can find the chat button on the bottom right-hand corner of your screen. And we'll get to as many of those questions as we can. And if we don't have time for all of them, we will email you around a response to your questions after the event. Everyone apart from our speakers will be on mute today, and that's just for ease of management in this new webinar world that we're living in at the moment. Today's event will run in a couple of different parts. In the first part, we've got our lovely speaker, Rachel Bilton-Simek. On my screen, she's in the corner there, and she'll be talking to us about death and dying, and a bit more about what is palliative care and what kinds of considerations and services we might think about at that time of life. And then after that, we've got a number of panel members, and we're going to put to them the questions that have been on your mind that you've let us know about, and hopefully we'll get to some in the chat as well. So I don't think I need to talk much more at this point. I'm very grateful to Rachel for taking some time out of her day and joining us here. Rachel Bilton-Simek is a palliative care nurse and educator at Clare, Holland House, and she talks beautifully about death and dying, as you'd expect. And so I'm going to hand over to you, Rachel, to tell us some of your wisdom and what we might need to know at that time of life.
Well, thank you very much. I just want to make sure everyone can hear me. I have actually got a fan going on in the background. I'm enjoying a new part of my life, which I'm sure some of you ladies will appreciate. Look, I guess I just want to start by saying a lot of people talk about, when it becomes time, and that's a very confusing kind of thing, because time is a funny thing. And the concept of, when is it time to have palliative care? That's another really confusing thing for a lot of people. And I guess historically, most people associate palliative care with just the dying part of life. It's where you go when the doctor says so. So I guess the first part of the whole conversation is around actually around managing your health and understanding what's going on with your body. Because a lot of the time, particularly when we're first diagnosed with an illness, we're so caught up in, often the shock of the diagnosis and what the treatment looks like. We haven't actually had a conversation about, is this a life-limiting illness? Is this an illness that in the long term is going to be considered life-limiting, because that's the first part of the conversation. If you don't know you have a life-limiting illness, well, you can't really ask the right questions because you don't really know who to ask and what to ask. So what is a life-limiting illness? Most people associate, death and dying, particularly earlier in our lives, with cancer. But actually there's lots of illnesses that we die from, and even cancer we don't necessarily die from. Maybe some of you out there are survivors. That was a conversation 20 years ago that we would never have had. So I guess we're talking about, when we say life-limiting illnesses, what we're talking about are things like advanced cancer, obviously, motor neuron disease, any of the neurodegenerative illnesses where our nervous system and our brain degenerate over time. So that does include things like Parkinson's and dementia, because obviously once those systems start to fail, we do eventually become more vulnerable to more things, and we probably are going to have to face the end of our lives. Heart failure, liver failure, kidney failure, advanced emphysema, obviously infectious diseases if you're vulnerable. If you live in a non-developed country, that might include even things like malaria and HIV. And I guess in a developed country, you'd also have to consider that a lot of our infants that perhaps pre-neonatal care wouldn't have had a life, then have a life, but often with congenital issues that might mean that their life is compromised. So I guess that's the first thing, is knowing about your health, what's actually going on with your body. So I had a conversation with an elderly woman recently who's recently come on to our books. She was told she had chronic obstructive pulmonary disease, but she actually didn't really know what that was. So obviously when the doctor suggested palliative care, she was shocked. She didn't really know, oh my goodness, what's happening. The whole concept of palliative care is not that it's a thing we do when we're approaching death. It's actually, the concept of palliative care is we actually think about what sorts of things can be done for me that won't necessarily cure my illness, but will improve my quality of life. So that could be a whole range of things. It could be anything from medical things like palliative chemotherapy. Palliative chemotherapy, I hear you say. No, I don't, because you're on mute. But a lot of people associate that chemotherapy is only of a curative nature. Palliative radiation therapy. Again, we might be having radiation to prevent bones from breaking or to help with pain. So it can be quite medical things to things that are, when we're talking about quality of life, might be about wrapping our head around our spiritual journey, or knowing who we can trust and who we can talk to as we negotiate our illness. And in fact, some of you out there might have chronic illnesses, and you might even be thinking, oh my God, how can you be mentioning palliative care when I've just got a chronic illness? But actually it begins with us in our well state, thinking about who we are and what's important to us. Those are really good things to know, because then if we are diagnosed with a life-limiting illness, we can extend on that. Where do I want to be when I die? Do I really want to be in intensive care? Or do I want to be at home with my, rabbit and my geraniums? Who around me do I trust? Who can look after me if I need physical assistance? We know that 70% of well Australians say they want to die at home, but the reality of the dying process is that's not always possible. So we need to construct a way of thinking that we can cope with what's happening to my body, how might my body change as I get sicker, and what sort of support am I going to need to be where I want to be. If I want to be at home, do I have family and friends that are willing to support me? Have I tapped into resources that I already could be using as part of my chronic illness? That in and of itself is the true nature of palliative care. It's about having support around you, whether that's someone to do your shopping or someone to sit with and provide you with companionship through a time when you're too fatigued to leave your bed. That really is the kernel of palliative care. I guess in the last 20 years, as we've seen the medical fraternity kind of see the role of palliative care as something that's more within their province, it has become a little bit medicalised. And so, you hear a lot of language around, is it a palliative approach? Am I receiving normal palliative care or specialist palliative care? Which sometimes complicates things, I think. And it doesn't need to be complicated. I think if you've got a relationship with your GP and you're asking really good questions about, what's wrong with my body, what's going to happen to it, what might I need as I become sicker. If we can start having those conversations, then we can start having a meaningful dialogue with each other about what we want. And of course, that then leads to being able to have a conversation with Emma and her team around advanced care planning. Do you all understand? Just nod, I think might be the way to go. Does anyone out there have an advanced care plan? Just a simple nod. So you do. Tracy, have you got one? No, she doesn't have one. So it's always that thing that we want to put off. And I guess the way and Emma, of course, will have other ways of talking about it, but it's about really just starting a conversation. What's important to me? Is it important that I have certain religious rituals? Is it important that I have my pets near me? Am I actually a really private person? And I need to actually think about how that's going to look as a private person. Asking questions is really the best way to start. Now, the fact that you guys have signed into this webinar tells me that you'll probably already have some, thoughts about this stuff. You might have a relative or you yourself might be, have a life-limiting illness. And it starts with understanding your body. It shocks me sometimes that people come away from medical appointments really not understanding what's going on. Once you understand that, then you can start to build on that. Some people, obviously find these conversations very challenging and actually need the support of a social worker or a psychologist or a counsellor. I know certainly the cancer services at Canberra Hospital provide some counselling services. I know that Carers ACT have some counselling services. It's really about trying to have safe places where you can actually explore what you think about all this stuff. The medical fraternity and even nurses tend to talk a lot about comfort care. I like to challenge them and say, well, I don't know what makes you comfortable, but I'm sure it's not the same as what makes me comfortable. And that's where we need to start to unpack that. We can't allow the system, if you like, to just go, oh, she only wants comfort care, because that actually doesn't tell us anything. So if you're hearing conversations around comfort care, that's a pretty good clue that we're thinking about things of a non-invasive, non-burdensome nature. And it's an opportunity to actually plant the seed of what that looks like for you. Frankly, if anyone plays Enya or dolphin music when I'm dying, I will haunt them. I like neither. I particularly dislike lavender, and if anyone likes a vanilla candle, I will cry. So, these are actually the things that matter. At the end of the day, it's actually about the people around you knowing what you value. Certainly in Western culture, we can have some very kind of average ideas about what end of life looks like. And we as individuals, as people, need to plant our seed on what does that look like for you. If you have spent some time in hospital, you'll know that being in hospital is a pretty challenging time. And sometimes it can be really hard when you're sick and you're vulnerable to ask questions. So I always say, take an advocate with you. Make sure you've got someone that can advocate for you and ask questions. I think that's a really important thing. If you're coming home from hospital, you know, I see a lot of people arriving home from hospital with a woolies bag full of medication. They don't know what they're for, when to take them, who to call, all those sorts of things. And that's where we need to, as people, when I get home, what do I do when I run out of medication? Who do I see if I feel unwell? Who should I go to? And having a bit of an action plan. I think that's a big part of palliative care as well, is also planning for, I suppose you're hoping for the best, but you're planning for the worst. What's the worst thing that could happen to my body, and who will I ring? Who will I turn to, and how will I get the help that I need? Because if you can answer those questions, that avoids a lot of stress. If you're being given a lot of information like today, and you're thinking, wow, this is too much information, these days there are lots of online resources. Palliative Care Australia offers some lovely resources. Palliative Care ACT. The Calvary Hospital website has actually got some information specific for families and patients, be that around managing pain, managing eating and drinking. And Catherine, I think Catherine is there, but she can't hear me. You're from Canberra Hospital, aren't you? Are you from Canberra Hospital? She's going to, no, she's not. Oh, I've missed, there must be another Catherine. I'm not sure what's on the ACT Health website, but there's certainly lots of resources. I encourage you to educate yourself. We've started to couch a term now out in the community called death literacy. It's a little bit like health literacy. So health literacy gets us to explore managing our medications, you know, coping with that sort of stuff. Death literacy is about understanding what is dying and what's the scary part for me. What are the things that I worry about? Have I asked someone what it is that worries me? Often we're fearful of pain, and that may not even be an issue. It's not an issue for everybody that's dying. Obviously, becoming fatigued and tired and weakened may mean that you might be spending more time in bed. If lockdown's anything to go by, I don't think much will change for me. I might stay in my pyjamas and stay in bed. That could wear a bit thin, of course. Making sure you're not getting a bed sore, making sure that you've got access to nutrition and fluid, you know, all of those really basic stuff. You know, palliative care is not rocket science. The doctors like to think it is. Don't tell them, but it's not. It's really about good care. It's around being safe, being supported, and having your basic needs met. And really that's as scientific as it gets. Now, if the people around you know what that takes to create that space, then you're in a great space to be palliated. Now, services. This is a funny conversation. So people say to me, well, there's a 19-bed hospice facility, soon to become 20, I can't add up, 26 beds. And a lot of people say, well, why is a hospice so small for a whole territory? The reality of it is that you don't have to die in a hospice. Not everyone will have a complex end of life. For most of us, we'll probably just fade away. And, you know, being in an aged care facility, being at home, that might be where we die. If I'm lucky, I'll die on the toilet at the mall after a particularly hectic shopping mission. I don't know if I can write that on my advanced care plan. I love shopping. So, you know, thinking about, well, how can I make my space the best it can be? I've lost my train of thought. It's very hard when no one's talking to me. I don't like WebExing. This is weird. Some of you are probably thinking, oh, I know where I was. That's it. Good. So why is there only a little hospice? Not everyone needs one. The healthcare generally has divided palliative care into some fairly sort of abstract ideas. So we talk about primary or basic palliative care. So that's just normal care, like you'd expect good quality care in an aged care facility. I'm being washed and dressed and fed, and you know, I'm not getting bed sores, I'm being provided companionship, all of those things. Primary basic palliative care. Then I suppose we then talk about specialist palliative care. And this is usually for people who've got a complex array of symptoms. Their symptoms may not be responding to normal medications. They might have some, you know, they might have a history of mental health issues, or they've got a really complex disease process, or maybe they've got a couple of diseases going on at the same time. And that's when specialist palliative care tends to kick in. So if you're in a hospital, you've got a life-limiting illness, maybe you've decided you don't want what's called the MET team, and you don't want CPR, and you're thinking about going home with your chronic illness. If you actually say, hey, I'd like some palliative care, not only will the doctors be shocked, but they'll be also pleased, because it means that they can refer to palliative care nurses and doctors. In Canberra at Calvary Hospital, we have a consultancy nurse and a couple of doctors who will see people on the ward, talk to the families, and map out what that might look like for that person. Some people very early in their illness may have a conversation with their GP that says, look, you know, I really don't want to keep having the acute treatment. And we may actually initially see them as outpatients. Obviously, during COVID, we're doing that as telehealth, but it means that you're getting that contact with a specialist palliative care doctor who will then contact your GP, maybe refer you to some other disciplines of healthcare and support you where you're at. So that's another way, being seen by an outpatient. There's actually a couple of different outpatient spaces that you might start to make contact with palliative care. So at Canberra Hospital, we have a clinic for people with end-stage renal failure. That tends to be called supportive care, and it's a little bit different to palliative care, but it's the differences are fairly semantic, I would say. So if you've had renal failure, and let's say you said, oh, I don't want to keep having dialysis, then we might see you in a supportive care clinic as an outpatient. If you have something like motor neuron disease, there's a special multidisciplinary outpatient clinic run out of the University of Canberra. And again, that allows us to start paving the way about what you need at this time and what you might need in the future. Some people, of course, will be at home. They might have a conversation with their GP. They want to stay at home, and a referral will come to our community specialist palliative care service. So we sit and we look at all these referrals that we get, and what we basically do is we have a conversation with the person that's ill and have a conversation with the family, and we try and ascertain the complexity of the scenario, and then we what's called triage. It's a fancy word for sorting through the most urgent referrals, and then we try and see those people at home as soon as we can. So we have urgent. We usually see them within 24 to 48 hours. Semi-urgent, about a week. Non-urgent, sometimes can be up to 2 weeks. And obviously with COVID, it's quite challenging to get everybody seen. But that's what we try to do. So the first contact with palliative care might just be a conversation with a nurse at your home.
Rachel, I just have to let you know, another minute or two.
Sure,
and,
sure. And then, of course, we've got the inpatient specialist palliative care service provided at the hospice. 3 reasons you might come to the hospice. You might have realised, or you might recognise that you're coming to the end of your life, and this is in fact where you want to die. Or maybe you don't have the resources to die at home, and dying in the hospice feels like a safe option. Or you, oh dear, this WebEx thing, it's doing my head in. I keep losing my train of thought. Oh, yes. So you might come to the hospice for that. The other reason, some illnesses take a long time. So motor neuron disease can be quite a long illness. So sometimes we offer what's called respite, and that's organised with our social workers. So people come and spend 2 weeks with us, gives everybody a break. We realign the care and we go from there. And I guess the third reason is really often for symptom management. So you're at home, you're managing most things, but maybe pain's getting a little bit tricky. We might ask you to come into the hospice so we can manage your medications and give you some support through all the disciplines and set you to right so you can pop back home. So that's really, so I think I've sort of covered, you know, how do you get started? I've covered the services. Dying in itself is a little bit like, I suppose it's just a gradual process. If you're lucky, it's gradual. You know, you don't want to eat. Oh, regional areas around Canberra. I've got a question here. That's a really good question. So, someone's asked a question: what sort of palliative care is available for people in regional areas around Canberra? It's a topical question because Southern Area Health, which is attached to Queanbeyan and some of those regional areas, has actually recently signed a contract with an organisation called Hammonds Care. And Hammonds Care are a conglomerate of doctors and other disciplines. And so they are actually a separate service to us. Obviously, we talk to them. And if patients need hospice care, you know, they may actually contact us. There's also a new palliative care service out Mossvale Way, I think. I'm not sure if it's open yet. And I mean, to be frank, you know, Gorman Hospital, some of the regional smaller hospitals are quite capable of palliating people who only need that sort of very basic palliative care. As far as services at people's homes, that really depends on which region you sit in, whether you can tap into the Hammonds Care services, or there are services attached to the South Coast. Obviously, it gets much trickier. And someone's asked me a question: what happens when you die? Is there a standard shutdown of your body and mind? Not really. I guess the way I like to approach dying is I like to say it's not a disease state. It's an altered state of a human being. And it's going to depend on what illness processes are going on. I'd like to say for most people, it involves a changing in your respiration, not being able to swallow and therefore not eating and drinking. And in fact, most people in the normal dying process lose the appetite and thirst anyway. Our body makes some interesting adjustments. We produce a little bit less wee. Obviously, we may not be in control of our bladders. We may not always be in control of our bowels, just depending on the disease process. And obviously, you know, once you've stopped eating and drinking, you've got things like the kidneys are starting to wear out. If you've got a pacemaker pounding away, well, that could be a bit tricky because we've got to wait till, you know, everything else shuts down and then eventually your heart will shut down. Interesting thought. If you do have a pacemaker that's got a defib as part of it, then you need to have a conversation with your doctor about when, you know, that will need to be deactivated so that you can be allowed to die in the normal process. But for most of us, it's just a fading away. Not everybody gets pain. Some people do. Most people, although they might make a lot of respiratory noises, you know, it probably sounds like me with a heavy cold snoring. which is pretty gross. Doesn't bother me, but obviously bothers the rest of the house. And it's the same with the respiratory noises that a dying person makes. It can sound pretty grotty because we're not swallowing and managing our secretions. Obviously, even with primary palliative care, most of the sort of what we call anticipatory prescribing, or the medications that we might suggest or put in place, are often around managing any emerging respiratory distress. So obviously, if you're trying to breathe a lot and it's causing distress, if there's distress generally, which can come from a variety of sources, most of us will have some sort of minor delirium where we're not quite with it. We're in and out, and that really upsets some people, and other people are quite okay with it. So we do have some medications to manage that. Sometimes we will attempt medications to try and reduce secretions, but for the most part, the medications are just parked there so that if symptoms emerge, we can use our best clinical judgment with the family and use those medications to minimise the distress that might come about. Does that answer the question?
It does, and thank you, Rachel. I'm just going to stop you there because we've got some questions now that that have come through earlier. But that was a really fantastic, informative chat about some of the things we can expect, and you did really well at managing the webinar aspect. I know it's not as easy, I know. And in the past, we've run this event face to face, and it is a great thing to do face to face, but for obvious reasons we can't do that now. So I'm going to move on to the first sort of panel part, and I'm going to invite Tracy Gillard, who's the CEO of Palliative Care ACT, to kind of answer some of these questions with you too, Rachel, because these are the palliative care questions. Now, Tracy, can you just give a wave? I'm just going to check that people can see who you are. And I'm going to direct this first one to you, Tracy. Is there anything that you would like people to know about palliative care?
Thanks, Kate, and thanks, Rachel. That was excellent. I love the pragmatism and the self-deprecation. Always great on a webinar. You did a great job. A few things that came, slamming home to me that I was writing notes on. A few words that I think are really critical for people to take away are things like knowledge, access to education is really important around this space, not only for the person who is approaching the end of their life, but the people around them that are supporting them. And that leads to advocacy. If you have a bit more knowledge around these things, and all that information Rachel was giving you supports people who are around the others to be their advocates when they're full of information and full of care processes and things like that. Community. Accept help. A lot of people don't accept help generally during their lives. A lot of us are very independent these days in our culture. A community around somebody who's dying is incredibly important, just as important as it is around people being born, that end of life. I think these spaces are quite similar in lots and lots of ways. Choices. Know what your choices are, and be very brave about making choices that suit you in a range of scenarios. And I was brought up where when a doctor told me something, I just listened and nodded and took it in as the expert. Same with the policeman. I've always thought I've done something wrong when I see a policeman, but take that control back, which is everybody's right to do, particularly important at this end of life. And care. Care for yourself, care for others. There are lots of care options available. In Palliative Care ACT, we have a volunteer program who can offer some care. We have opened recently a non-clinical respite centre so people can come and have a break within limitations of what we're able to offer. So practical supports are available, furniture, ramps, lifters, all of those sorts of things. And the likes of Rachel and Palliative Care ACT can link you with these services. Emotional support is really important. One of the questions I think we've received is about pastoral care. Pastoral care, counselling, support and friendship are really important as you go through end of life. And the medical, is one part of a very much bigger approach to palliative care in the ACT. So there are lots of things around there to support people.
Thank you, Tracy. That was great. Now, I'm going to direct this next one to you, Rachel, then maybe Tracy, you might have something to add as well. And this one struck home for me. And the question is, as well as from a professional point of view, but as from a family member point of view, how do you approach the subject of dying with someone who's terminal? I know that I found that really hard with one of my family members. Rachel, have you got any tips for that?
Look, I think generally people give us little windows, little opportunities when they want to talk about it. I think we just have to be listening. People will say things often, you know, quite sort of general things, but if we're listening, often they give us the chance. I guess if it's a conversation that has to be had out of pragmatic need, I guess often it's about getting people to reflect on how they're feeling and what's going on with their bodies. You know, a conversation I might have is, you know, gosh, you've been in hospital, you know, 5 times this year, and you know that dreadful lymphoma just doesn't seem to be going away. You know, what's the plan? You know, where are you up to in terms of managing that? So I think you've got to give people the opportunity to take the lead. And you've got to be listening. Remember, we talk about death and dying in very peculiar ways. We say things like, you know, look, I think it's about time I sold the farm. You know, I reckon any time soon I'll be pushing up daisies. You know, we say lots of strange and euphemistic things. And for those of you where English isn't a first language, you'll be thinking, what? Do I have to become a gardener? You know, but I think if we're listening, people give us little windows. And even just saying, you know, do you want to talk about what's happening with your body? Do you want to talk about what's going on for you right now? And look, for some people, they don't want to talk about it for a good reason. And we have something called cognitive dissonance. So I like to believe I'm a world-leading model. I don't like to listen to my doctor tell me that my BMI is too high. So I have a bit of cognitive dissonance, and that's what we tend to do. You know, at a very deep, instinctive level, we all want to stay alive. And sometimes the emotional and spiritual challenge of having that conversation is simply too hard. And we have to let people do that too. Nurses can sometimes, or doctors can sometimes say, oh, you know, or you might be thinking, oh, she's in denial. No, they're not in denial. They're coping with their situation as best as they can. And sometimes that means saying or asking for things that you think, really? But that's okay.
Thanks, Rachel. And I notice you've popped in the chat that Palliative Care Australia produces a booklet called Asking Questions Can Help. So that's probably part of that subject too. Now, Tracy, this one might be one that you can help us with. Somebody has asked about the difference between the roles of a palliative team that might visit you at home and the usual community nursing team, which also visits you at home, and they're both services we have in the ACT. Can you talk a bit about what the difference there would be?
I suspect Rachel will probably be better at answering this than myself. However, I want to give a plug while we're here talking about resources. On Palliative Care ACT's website, we have under the tab Resources, Palliative Caring, which is a booklet for carers. That's got quite a lot of information in it that I think that you would, you know, as a carer, I nursed my mother at home with motor neurone disease until she died. And I read this book and I thought, oh my goodness, if only I had had this book. And, you know, it gives a lot of things from practical and the theoretical and the contacts. So I'll just put that out there. With regards to the difference between a palliative at home team, which is generally a specialist palliative team, and the community nursing team, community nurses go into homes when there is a need for a sort of, I don't know, for example, with motor neurone disease, my mother had to be fed through a peg in her stomach. So the community nurses would go and make sure that that was okay, and syringe drivers and, you know, medicalised things that they will go in and maintain during somebody's illness. They will come into the home like that. With the palliative care specialist team, they do a little bit more. They're very tailored into, I think they can even write scripts and so forth. Rachel's probably better to describe things that can happen in that space.
Yeah.
Thanks,
well, I guess a big part of specialist palliative care is actually having someone skilled enough to talk to you about what you need, and then kind of, you know, figure out how we can best put that jigsaw puzzle of resources. And Tracy's totally correct. It might be that you've got a wound and the community nurse will come and do your dressing, but the palliative care nurse will be looking at the whole situation, looking at, you know, do you need equipment? Do you need to be shown how to do something, how to maybe give some medication? Do we need to liaise with the GP about getting some medication in the home? Do you in fact need to be seen by a specialist palliative care doctor at home? Is that something that we need to work out? We, because our team has got an occupational therapist, a physio, a social worker, pastoral care and doctors, often we're the interface with that team. Certainly we're much more active in terms of nursing care towards the end of life. Often if that means particularly more medication, we're often involved in ascertaining, you know, whether that's working, is it the right medication, that kind of stuff. We really look at the whole picture. So we are tasked with, well, that's the thing. We're not given a task. We're not here to do a specific clinical intervention. We're here to meet you where you're at and say, look, you know, obviously palliative care resources are needed in your home. What does that look like for you?
Thanks, Rachel. I'm sorry to cut you off there. It's
Please
just I'm aware that we're running out of time, and I can see that we're not going to get to all of our questions. So what I'm going to just remind you is that we will send you a list of the questions and their answers after this event. And so what I'm going to do now is actually move off the direct topic of palliative care, because we've got a couple of other people here with us today that I really want our audience to hear from, because there's some really important services that I'd like people to know about. So if I could just ask, so we've got Catherine Bell, who's the Director of Tender Funerals Canberra, and she's also a death doula. Catherine, can you give a wave there? And yep, there's Catherine. And we've also got Emma Awizen, who's the Manager of Advanced Care Planning at Canberra Health Services. And we've got Helen Connolly, who's with the ACT. She's the ACT Deputy Public Trustee and Guardian, and the Senior Director of Guardianship. Helen, can you give a wave too? That would be great. So I'm just going to direct a question at each of you so that people here can hear a bit more about the area that you work in, and we'll send some information about that too. So I'm going to start with you, Catherine. Catherine, you've got two hats you're wearing today. I'd like to ask you, what is a death doula, and you know, how can that be of help at the end of life?
So the term death doula comes to us because of the similarities that Tracy was talking about between the beginning of life and the end of life. People need a little bit extra at the beginning and the end. And so the death doula steps in for that non-medical support. That might be emotional support. It might be practical support around the home, meals, walking the dog, just helping out with the other children if there's children around, really practical basic stuff, as well as helping them to find information and work out what questions they want to ask. So when they do have time with their medical care providers, they're more prepared for what that conversation will look like. I use the term death walker to refer to myself. I did death walker training with Zenith Virago in 2015. And in that training, we learnt about advanced care directives, conducting funerals, preparing a body, the sorts of things that you might do as a funeral director as well. So from there, it became a logical leap to then start working with tender funerals.
Thank you. And if people feel like that is a service that they would like to have? How does one find a death doula or a death walker?
Usually a Google search. So it's one of those things you kind of have to know about it. A bit like birth doulas when they first started. If you happen to know somebody who knew about it, you would find out about it, and a word of mouth makes a big difference there. So it might be the palliative care team might suggest you need some extra support, or you might have stumbled across the term and decide, oh, actually that sounds really good. These people who practice as death doulas or death walkers are private practicing people. They're independent of the system. So it's about finding someone who aligns with your morals, your judgments, your religion, perhaps. So you might be seeking someone who is a specialist in your needs for end-of-life care.
Thanks, Catherine. That was a great explanation. I have so many more questions, but I need to move on. I'm aware that we've only got another 15 minutes, so we might be able to come back to some of those things. So, Emma, this next one is for you. What is an advanced care plan for, and how do we make one?
Thanks, Kate. And it's been really interesting listening to all the speakers up until now. I think you've really provided some really good information, certainly from the palliative care point of view, and learning more about the death doula. I'm also really interested. And I think that leads on to advanced care planning in the sense that what we've been talking about can all be added to an advanced care plan. So, for example, when Catherine spoke about a death doula or a death walker, if that is something that's particularly important to you, then that could be added to your advanced care plan. So the idea of the advanced care plan is enabling you to be able to document your preferences, your values, your wishes about the type of treatments and care that you may want at end of life. So the idea is that it is done in advance. So when we talk about an advanced care plan, we want people to start thinking about it really early on. We don't want you to get to an end stage where we're really having different types of conversations. It's about thinking in advance. It's about starting to have those conversations, which is exactly what we're doing today. We're talking about Dying to Know Day. We want to start talking about it. We want to normalise it, like Rachel was talking about. I guess also, like Tracy mentioned, making sure that we're making informed choices. So we want to get all of that information together, and then we can start to plan our own document. So it belongs to you. It is your document. It's no one else's. So you want to make sure that when you're putting together your document, it's all about you, and then you're then sharing that with those chosen advocates. So your chosen decision makers that you may have chosen through your enduring power of attorney. I know we don't have a lot of time today, but certainly, advanced care planning can involve an enduring power of attorney. It can involve an advanced care plan, documenting of your wishes, and it can involve a health direction. And we have some fantastic resources that we can certainly send out to you. And I know Claudia has mentioned that she'll be sending out a whole list of resources. So please don't hesitate to contact us, and we will either, we can speak to you, or we can send you out that pack. And we've got lots of detailed information that we can share with you. Just quickly, sorry.
No, go, Emma.
Really quickly. Also, the ACT Health website, if you just type in advanced care planning in the search bar, that will also provide you with a page that has all of our resources. And also palliative care in there. There's a really great booklet that's been developed when someone dies, and you can, at the moment that's not available as a link, but it will be shortly. So Tony has asked me to mention that, who I work with as part of palliative care. So I guess in a nutshell, please feel free to get in touch with us, and we can certainly provide at the moment telehealth sessions with you, and we can go right through our documents and how they work.
And so we'll send those contacts through as we send through the information pack that will come after this session. And I'd also just like you to know that if you'd like to know more about advanced care planning, you can join us in a session that Healthcare Consumers is running. Is it next week on the 24th of August from 2 to 3:15? And there's a link to it in the chat, but again, you can just call our office on 6230 7800 if you'd like to register or know more about that.
I really encourage you to join those sessions. Claudia does an amazing job with those. And we'll certainly make sure that we've got members of our team available too for any questions about, I guess, making sure you've got your documents available if you're coming through health services, etc.
Thank you, Emma. Okay, and my last question I have, well, it's probably not the last question. I'll see how far we get. We've only got 10 minutes left. But Helen, Connolly, I'd like to go to you. Can you give a little wave? People are often really confused and concerned about documentation around things like wills, the power of attorney documentation. What do you think people need to know about those kind of legal documents? What would you say to people just starting to think about those?
Well, it's consistent with all of the things that everyone's been saying this afternoon. To make decisions on your own behalf about what's important to you, your values, your will and your preference around both decisions for where if you're unable to make decisions on your own behalf, so if you have an illness or an accident or something that impairs your cognition, so it means that you can't, your capacity isn't recognised as a decision maker by yourself, then you're putting information out for people so that they know what to do, so that they're making decisions that genuinely represent your preferences. I encourage everyone, and I, do this when we're talking to 18-year-olds, to identify who you trust in your life, who you would like to make decisions if you are unable to make them. And that might be for a momentary thing. I fall over and hit my head. I'm happy for Claudia to make a decision about my about which hospital I go to and those sorts of things. And she can be a health attorney instantly appointed. But for bigger decisions like accommodation or health or finance, I want to be specific about who I want, either the groups of people or the individuals. And there's a formal document that you prepare. They're different in every state and territory, sadly, at the moment. But write it down. That's the best way to get that information out. The same thing is true for the preparation of a will. I think it's widely understood if you don't have a will when at the time of your death and you are unable to make one on your own behalf, then there's a situation of intestacy and there's laws applied, which means the court decides who inherits your assets. And that might not be something that you want to have happen. If you want to direct that and make choices around that, do so. The question, can you explain the difference between EPOA and power of attorney for money and things? Enduring powers of attorney or powers of attorney appointments can be for different decisions. So you can have appoint someone as your attorney for personal and health matters in particular, and that includes accommodation decisions, so where you live, if you're unable to live in the place of your choosing or unable to express that wish. It can include decisions around health, not about palliative care. Everyone's entitled to access palliative care, and not about end-of-life care. That's the sort of decisions that are clinical, personal, and a third party, so a substitute decision maker, doesn't make those. They might be informed through the advanced care planning documents that you've done with Emma and her team. You can appoint someone to act as a decision maker on your behalf for financial and property matters. They're grouped together in the ACT, and that can be given effect immediately or when you lose capacity. A person who has that authority, you've given that authority to, can make decisions about your day-to-day finances and other financial matters. If they make decisions about selling property while you're still alive, there's an extra layer of regulation around that. So they have to give additional information to someone, to an organisation, that's with the public trustee and guardian here, to oversight that. Does that medical decisions. If you appoint someone in the ACT, we are really looking, and I'm particularly motivated about making sure that people's decision-making rights are very, very strongly held by the person or by the people that they nominate to have support them. We have a provision in the Guardianship and Management of Property Act in the ACT, which is a health attorney. A health attorney appointment is made for a single health decision. It can last for a period of time, but it's just one health decision or one health matter. And a doctor or a dentist can appoint a health attorney on your behalf. It's usually someone that you trust who might be with you at a doctor's appointment. And they say, we're worried that you aren't able to make this decision yourself, or you can't offer a formal, legal, informed consent. Are you happy for Emma to be your health attorney for this decision? And Emma says, sure, I know that Helen wants those sorts of things. I'm happy with that. So the doctor appoints her, and Emma might sign a document for me around a particular medical procedure. An advanced care plan, having these conversations, dying to know conversations, is the best way to prepare for all of these things, because then you've given thought to and you've told the people you trust what information you want. The people are quite welcome to. The public trustee and guardian's a substitute decision maker of last resort. People do appoint the public trustee and guardian as attorney in both financial and property and personal and healthcare decisions. Personal healthcare decisions end up with the guardianship unit. We love it when you've prepared documents and give us information when you create or appoint us as your attorney, so that we are really giving effect to your preferences, following what's valuable and important to you, and exercising your will, representing you as best we can. And it's nothing about us. It's all about what the person who appoints us wants.
Thanks, Helen. And we're nearly out of time, but I just want to ask one more quick one, which is, if people are confused about the different documents, or they might not understand them, or have language barriers, or may not be able to afford legal advice, is there somewhere people can go for help to understand what those documents are and how to fill them out?
Absolutely. There's lots of information available online. People are welcome to ring the Public Trustee and Guardian's office, 6207 9800. I know sometimes it's hard to get through. People tell me that a lot. You can send an email to guardians@act.gov.au, or PTG, Public Trustee and Guardian at act.gov.au, and we can send out information or send you links. But always happy to talk to people about those things. And certainly at Wills Week, there's a lot of information provided about that.
Okay, thank you very much, Helen. Now, I wish we'd got to more of our questions, but there was so much good information in there. I know we'll just have to do it by email. So instead, I'd just like to really say thank you to all our wonderful speakers and panel members for being with us and supporting this today. So thank you, Rachel, Tracy, Emma, Helen and Catherine. And thank you, audience members, for being here with us today.